आप लोगों से फिर फीडबैक लूंगी कि आप लोगों को समझ आ रही है बात या नहीं आ रही है, ठीक है? Ectopic pregnancy is defined as implantation of the fertilized ovum outside the normal uterine cavity. And when it is outside the normal uterine cavity, there could be several sites. And the most common site is the fallopian tube. And as you all know, that fallopian tube has 4 parts. So the commonest part of the fallopian tube where ectopic pregnancy can occur is the ampullary part of the fallopian tube. Now the other sites where ectopic pregnancy can occur are the ovary, the cervix, in the abdominal cavity, and amazingly it has been found at the site of the previous cesarean section scar. Although it's rare, but it is a possibility that it can occur at the site of the previous cesarean section scar. Now there is another term which is called heterotopic pregnancy. And what is heterotopic pregnancy? It is the simultaneous presence of both intrauterine and extrauterine pregnancies. And this is commonly seen in those pregnancies which occur after in vitro fertilization, when more than one ovum is used for pregnancy. The incidence of ectopic pregnancy is 1 in 80 pregnancies, whereas the incidence of heterotopic pregnancy is extremely rare, and it can occur in 1 in 25,000 to 1 in 30,000 of pregnancies. So you can well imagine that heterotopic pregnancy is so rare. So if I ask you, what is ectopic pregnancy? Any one of you, what is ectopic pregnancy?
Implantation of normal fertilized ovum or outside the normal uterine cavity.
Yes. And what is heterotopic pregnancy?
Ma'am, presence of simultaneously 2 pregnancies, one intrauterine and the extrauterine.
And the other extrauterine. Now, what could be the etiology or the risk factors for ectopic pregnancy? Now, you all know that the natural or the normal phenomena of fertilization is that ovum is shed by the follicle from one of the ovaries. This ovum is picked by the fimbrial end of the fallopian tube, and fertilization takes place in the ampullary part of the fallopian tube. And then this fertilized ovum, it passes through the entire length of the fallopian tube and gets implanted in the normal uterine cavity. And then the further process of pregnancy, it continues. When this normal process is disrupted due to any cause, then ectopic pregnancy occurs. So you all know that the fertilized ovum from the ampullary part, it traverses the fallopian tube and gets embedded in the uterine cavity. And this is because of the propelling action of the fallopian tube. There are cilia present in the mucosa, help in the movement of the fertilized ovum from the ampullary part to the uterine cavity. So when there is damage to the fallopian tube, the tubal mucosa, any cause, process will get interrupted. And the first and foremost cause for this damage to the tubal mucosa is pelvic infection or tubal infection. And the commonest organisms which are responsible for this infection are chlamydia and gonorrhea. So damage to the tubal mucosa, damage to the cilia of the tubal mucosa hampers the movement of the fertilized ovum from the ampullary part to the uterine cavity, as a result of which that fertilized ovum, it is retained inside the ampullary part, and as it grows, it causes rupture of the tube because the fertilized ovum cannot be retained in the ampullary part of the fallopian tube for a longer time. So the first and the foremost cause of ectopic pregnancy, and remember we are talking about tubal ectopic pregnancy, is damage to the fallopian tube. Now, damage to the fallopian tube can also occur besides pelvic infection because of any surgery on the fallopian tube. For instance, a woman who has tubal surgery, either because of a previous ectopic pregnancy or she has history of tubal ligation. In that case also, although the tubal ligation, it is rare to have pregnancy after tubal ligation, but if pregnancy happens to occur because of failed tubal ligation, the risk of tubal pregnancy is more as compared to normal uterine pregnancy. Similarly, if there is history of a previous ectopic pregnancy, recurrence of another ectopic pregnancy is increased manifold, and the reason being that the part of the tube has been damaged, hampering the normal process of the propulsion of the fertilized ovum from the tube to the uterine cavity. Is this clear so far? जी अभी तक आप लोगों को समझ आ ये पॉइंट क्लियर हो गया जो डैमेज की बात सबसे पहले मैंने की है. The first and the foremost cause of tubal pregnancy is the tubal damage.
Yes, ma'am.
Then there are certain risk factors which increase the incidence of ectopic pregnancy. And what are they? If somebody has intrauterine contraceptive device for reasons for contraceptive purposes, and if the woman happens to become pregnant, the risk of tubal pregnancy is increased as compared to intrauterine pregnancy. That is one risk factor. Then, if somebody has history of surgery and more commonly appendicectomy, because if you remember anatomy, appendix is in close proximity to the pelvic organs. So if appendicectomy is done in such a way that it is followed by formation of pelvic adhesions, there are peritubal adhesions. So what will happen? The pickup of the femoral end, the pickup of the ovum by the femoral end of the fallopian tube will be affected, and because of peritubal adhesions, the smooth movement of the fallopian tube resulting in propulsion of the fertilized ovum from the tube to the uterine cavity, that is disturbed. So it is very important for the surgeons that when they are doing appendicectomies in young girls, they should be very careful so that they don't make the young girls subfertile, because or this make them predisposed to increased risk of ectopic pregnancy. Then other risk factors could be advanced maternal age, and it has also been found that ectopic pregnancy is more in smokers. Women who smoke, they are more prone to have ectopic pregnancy, and this is probably has something to do with the functional capacity of the fallopian tube. But this is also a risk factor. Now, how can a woman present with ectopic pregnancy? Remember that the clinical presentation of ectopic pregnancy is variable. You can't say that each and every woman with ectopic pregnancy will present with the same symptoms and signs. You must have a high index of suspicion if a young woman giving history of early pregnancy and having complaints of abdominal pain and pain, you must have a high index of suspicion for ectopic pregnancy. Because remember, there may be cases in whom there is no history of amenorrhea. There may be cases in whom there may be history of irregular menstrual cycle. So the clinical presentation is highly variable, and a proper history taking and examination is a must. But the usual symptoms could be period of amenorrhea, history of abdominal pain, history of vaginal bleeding, which could be just mild spotting, and the presentation of a woman with ectopic pregnancy may be acute, subacute, or chronic. So, acute presentation is usually because of rupture of the tube. And in acute presentation, there is a typical presentation. And why is that? Because the fallopian tube has ruptured. Usually, when a woman presents, she may be having hypotension, She may be having tachycardia. She is usually pale, or she may present in a state of shock. Otherwise, in subacute and chronic cases, the symptoms may not be that severe. There could be history of amenorrhea or not. Abdominal pain, lower abdominal pain or pelvic pain may be of dull nature. And bleeding, remember, in cases of ectopic pregnancy, usually the bleeding is mild. Severe bleeding or passage of clots, that is extremely rare in cases of ectopic pregnancy. Now, what could be the signs, or on examination, what could be the positive features? The woman may be pale or not. Pallor could be present or not. Then tachycardia, tachypnea. On abdominal examination, there could be tenderness in the lower abdomen. And when you do a bimanual pelvic examination, and remember, you do bimanual pelvic examination only in cases of subacute or chronic. She might be tender on pelvic examination, especially when you touch the cervix. A mass may be felt in one or the other adnexa, and the size of the uterus usually is normal or slightly bulky. So what could be the differential diagnosis? Usually you have to differentiate ectopic pregnancy from a normal intrauterine pregnancy. The other differential diagnosis could be threatened abortion, because in threatened abortion also there is history of amenorrhea, there is history of abdominal pain or mild spotting. Then she could be a case of, what could be the other disorder of early pregnancy? She might be a case of gestational trophoblastic disease, but remember, in that case, the size of the uterus is more than the period of gestation. So these are some of the differential diagnoses which you must think of when a woman presents in early pregnancy with any of these complaints. So after taking history and doing her clinical examination, then what investigations you should do so that you can, which can help you in confirming your provisional diagnosis. There are two important investigations besides the routine ones. Amongst the routine investigations, obviously you will go for a complete blood picture. And if she is a case of ruptured tubal pregnancy, her hemoglobin will be low. But the specific investigations which are required in suspected cases of tubal pregnancy are, one is the transvaginal ultrasound, and the other is serum beta HCG levels. Now, the transvaginal ultrasound. Why I'm saying transvaginal ultrasound and not transabdominal ultrasound? Because transvaginal ultrasonography has more sensitivity as compared to transabdominal ultrasound. It has higher resolution. So if facilities are available for transvaginal sonography, go for that. Now, what do you expect in cases of tubal pregnancy? or what are you supposed to see? If on ultrasound you can see a clear evidence of intrauterine pregnancy, there is a proper sac present there or even a cardiac flicker there, then that excludes tubal pregnancy. But at the same time, if the patient is symptomatic, you must also see for heterotopic pregnancy, although it is extremely rare. But if the patient has symptoms and you happen to see evidence of intrauterine pregnancy, then you also should go see for presence of heterotopic pregnancy, which is the presence, simultaneous presence of both intrauterine and extrauterine pregnancy. The other thing which you should see on ultrasound is if the uterus is empty, there is no evidence of intrauterine pregnancy, then you should have a close look at the adnexa of the patient. Look for any gestational sac outside the uterus or presence of any mass outside the uterus. Sometimes even you can see a sac with cardiac flicker outside the uterus. And this is called intact tubal pregnancy. Then if you are suspecting a ruptured tubal pregnancy, then what could be the positive finding on ultrasound? There will be free fluid in the pouch of Douglas. There will be free fluid in the pouch of Douglas or in the peritoneal cavity. So in most of the cases, history examination and ultrasound is enough to make the diagnosis of ectopic pregnancy. Do you get this so far? अभी तक आपको समझ आ गई है?
Yes, ma'am. मैम फ्री फ्लूइड कब मिलेगा पाउच डगलस में?
फ्री फ्लूइड उस वक्त मिलेगा जब ट्यूब रप्चर हो जाएगी. ट्यूब अगर रप्चर हुई हुई है तो हीमोपेरिटोनियम होगा ना. हीमोपेरिटोनियम अल्ट्रासाउंड पे कैसे नजर आएगा? It will appear like a fluid in the pouch of Douglas, or if there is massive hemorrhage inside the peritoneal cavity, this fluid can also be seen not only in the pouch of Douglas but in the peritoneal cavity as well.
Okay, ma'am.
Is this clear so far? Now
Yes,
the
ma'am.
other test is serum beta-HCG levels. Now, before going for serum beta-HCG levels, a simple test can be done, and that is urine for pregnancy test. If the findings of ultrasound suggest tubal pregnancy and you go for a urine for pregnancy test and it turns out to be positive, this is also supportive. But remember, if the urine for pregnancy test is negative, but the other features are suggestive of tubal pregnancy, this does not exclude tubal pregnancy. Urine for pregnancy test, if it comes out to be negative, does not exclude tubal pregnancy. Is this clear? Now, what is the logic of doing serum beta HCG levels? What happens to HCG is human chorionic gonadotrophin. What happens to beta HCG during normal pregnancy? Normal uterine pregnancy. These beta HCG levels, they are doubled after every 48 hours in normal intrauterine pregnancy. But in tubal pregnancy, this doubling time is delayed. This doubling time is delayed. And beta hCG levels, they are helpful in confirming or excluding tubal pregnancy, usually in subacute and chronic cases. Because I've already told you that acute cases, when the tube has ruptured, you don't have much time to go for serum beta hCG levels. Because serum beta hCG levels, they take about, the report comes in about 8 to 10 hours. So you can't, if somebody has a ruptured tubal pregnancy, you can't wait for so many hours and then go for management. But in subacute and chronic cases, you can wait and then you can interpret the report of beta hCG and match with the clinical findings. Now, the management of ectopic pregnancy is divided into 3 categories. One is expectant management. The other is medical. And thirdly or lastly is the surgical management. Now, there are certain criteria which need to be fulfilled for each type of management. Expectant management, as the name is suggesting, that you will wait and see. You are not going to intervene. And this is only considered in those cases where the patient is hemodynamically stable. When I say hemodynamically stable, it means that your blood pressure, pulse, they are within normal limits. Patient has no acute symptoms like abdominal pain. When you do her ultrasound, you don't find any free fluid in the pouch or in the peritoneum. And the patient is cooperative with you and is willing to come for follow-up. This is very important. Because if you find out the patient is not cooperative, she can be lost to follow-up, then you can't go for this type of treatment. So this is very important. And for this, you have to counsel the patient and her attendants that, look, we are going to observe you strictly, because remember that once you are going for expectant management, you need very close surveillance of the patient, because at any time it is a possibility that your expectant management is converted into either medical management or surgical management. Is this clear about expectant management? जी ये बात समझ आई है आपको expectant management की? Are you people with me?
Yes, ma'am.
मैम ये लास्ट पॉइंट दोबारा रिपीट कर दें एक दफा.
देखिए, एक्सपेक्टेंट मैनेजमेंट का मतलब है कि आप पेशेंट को कोई ट्रीटमेंट नहीं दे रहे, ठीक है? आपने उसको क्राइटेरिया जो बनाया हुआ है उसमें देख लिया है कि क्या वो फुलफिल कर रही है. क्राइटेरिया ये है कि पेशेंट जो है, शी शुड बी हीमोडायनेमिकली स्टेबल, शी शुड बी क्लिनिकली स्टेबल, शी हैज नो acute symptoms. On ultrasound, there is no evidence of rupture of the tube. और मैंने आपको ये बताया था कि rupture of the tube की वजह से क्या हो सकता है कि there could be free fluid in the pouch of Douglas or the peritoneal cavity. ठीक?
Yes,
और
ma'am.
दूसरा इसमें ये है कि the serum beta hCG levels which we have done, the baseline levels, they should also be extremely low. they should be at least below 1000. ठीक है? अब
Okay, ma'am.
एक्सेप्टेड मैनेजमेंट का मतलब ये नहीं होता कि पेशेंट को आप ये एश्योरेंस दें कि बस अब आपका कुछ भी नहीं करना, उसको लेबल कर दें एंड देन सेंड हर होम एंड डू नॉट फॉलो दैट केस. This doesn't mean that the patient should not be followed up. Expectant management का मतलब ये है कि पेशेंट का फॉलो अप रहेगा. फॉलो अप तब तक रहेगा जब तक उसका बीटा HCG लेवल्स नेगेटिव नहीं हो जाते, क्योंकि जब उसके नेगेटिव होंगे तो तभी आप अश्योर हो जाएंगे कि जो भी उसकी थी एक्टोपिक प्रेगनेंसी का एविडेंस वो अब रिजॉल्यूशन हो गई है उसकी. ठीक है? पेशेंट नीड्स टू बी फॉलोड अप. दूसरी बात ये है कि जब आप एक्सपेक्टेड मैनेजमेंट किसी की करते हैं, possibility is, the great possibility is that no further treatment will be required. But there is a remote possibility as well that at some stage during the follow-up, there is deterioration of the condition of the patient, and you have to go either for medical management or surgical management. That is why you want to follow up your patient. Is this clear now?
Yes, ma'am.
Yes,
Excuse me,
ma'am.
ma'am. It means that we'll decide which treatment we'll opt. It depends on the condition of the patient.
जी बिल्कुल, on the condition of the patient, on the ultrasound report and on the beta HCG levels.
Thank you.
Now the second, sorry, did you say anything?
No, ma'am.
Achha. The second management is the medical management. Now before going for medical management, certain criteria must be fulfilled. And what are those criteria? Again, the patient should be hemodynamically stable. That is the first and the foremost. Secondly, when doing ultrasound, there should not be any free fluid in the pouch of Douglas or the peritoneal cavity. And when I say this, I mean that there is no evidence of rupture of the tube. What about the beta HCG levels and the size of the adnexal mass? Now, when I say adnexal mass, it means the size of the tube which has that ectopic pregnancy. Now, that size of the mass should be less than 4 centimeter. Less than 4 centimeter. And beta HCG levels should be less than 3000 international units per liter. Do you get this point? So if these criteria are fulfilled, then only you consider medical. इसमें कोई आप लोगों को पॉइंट समझ ना आया हो?
No, ma'am.
मेडिकल एक क्राइटेरिया जो है, जी, any confusion in the criteria for medical management?
No.
Now, which drug is used for medical treatment? It is called methotrexate. Now, methotrexate is folic acid antagonist, and it inhibits DNA synthesis in the trophoblastic cells. So how does it act? It inhibits DNA synthesis in the trophoblastic cells. And it is folic acid antagonist. So calculate the dose of methotrexate by calculating the mass index. And the dose is 50 milligram per meter square. The drug is given intramuscularly. What's wrong?
Hello.
Didi, I
Assalamu
can hear
alaikum,
you.
ma'am.
Walaikum
मैम
assalam.
काइंडली मेडिकल ट्रीटमेंट रीड कर दें, सिग्नल इशू की वजह से मुझे सुनाई नहीं दिया.
Medical treatment?
यस मैम.
Acha, okay.
थैंक यू.
Before starting medical treatment, certain criteria must be fulfilled. Criteria. Can you hear me now?
नो मैम, अभी भी आवाज ठीक नहीं आ रही.
No, ma'am.
नहीं, अभी नहीं आ रही.
हेलो.
I can hear you. मुझे तो आप लोग की आ रही है.
मैम अब
मैम
ठीक है.
आ रही है.
बीच में अटकने लग जाती है तो क्लियरली समझ नहीं आ रही कुछ भी.
अब आ रही है.
यस मैम.
अच्छा, अब मैं ये कह रही हूँ कि मेडिकल ट्रीटमेंट से पहले certain criteria must be fulfilled. And what are these criteria? Number one, the patient must be hemodynamically stable. Then, secondly, on ultrasound, there is no evidence of intrauterine pregnancy, and the size of the adnexal mass or the size of the tubal ectopic pregnancy should be less than 4 centimeter in diameter. There should be no free fluid in the pouch of Douglas. Clear so far?
यस मैम.
अब दूसरी इन्वेस्टिगेशन जो मैंने आपको बताई थी कि जो इस कंडीशन में हम करते हैं that is serum beta HCG level. So for medical treatment, the serum beta HCG level should be less than 3000 international units per liter. अगर ये क्राइटेरिया फुलफिल कर रही है पेशेंट, then you will suggest medical treatment. मेडिकल ट्रीटमेंट के लिए कौन सा ड्रग यूज किया जाता है? इट इज कॉल्ड methotrexate. Can you hear me?
Yes मैम, आई कैन हियर यू. methotrexate.
Methotrexate. What is methotrexate? It is folic acid antagonist. How does it act? It inhibits DNA synthesis in trophoblastic cells. How is the dose calculated? By calculating body surface area. And the usual dose is 50 milligram per meter square body surface area. The drug is given by intramuscular injection. Now, before starting treatment, you need to do certain tests. Because this drug affects the liver function tests, the renal function tests. So before starting treatment, you must get complete blood count of the patient, her liver function tests and her renal function tests. If they are within normal limits, then you go for methotrexate. Now, how do you come to know that the methotrexate that you have given is being effective? The effectiveness of the methotrexate is tested by measuring the serum beta hCG levels serially. Now, you have to do serum beta hCG levels before starting treatment, then on day 4, day 7, day 11. Now, if between 4th and the 7th day, the beta hCG levels, they have fallen by 15% of the baseline, it means your and the patient is asymptomatic, hemodynamically stable. It means your treatment has proved. Once there is downward trend in the beta hCG levels, then you start doing it weekly, and this is continued till the beta hCG levels, they become undetectable. Is this clear? Is medical treatment clear?
Yes, ma'am, it's clear.
Now, when you give methotrexate to any woman, it is important that you advise her that she should avoid pregnancy for at least another 3 months. Because if she conceives earlier, there is a possibility that methotrexate will have teratogenic effects on the subsequent pregnancy. So this is very important. And another point is that methotrexate should not be given to lactating mothers. If somebody has a baby who is being breastfed, then either you avoid methotrexate or you have to stop breastfeeding of the mother. So these are two important points which must be remembered. Is this clear? The clear हो गई ये बात? दो points.
Yes, ma'am.
Now coming on to the surgical management. Now surgical management is the preferable management in acute cases where you find out or you diagnose that the tube has ruptured inside. In that case, there is no option for expectant management or medical management. Now, surgical management can be done laparoscopically or via laparotomy. What is the difference between the two? When I say laparotomy, I mean that you open the abdomen by giving an incision and then you do the surgical management. Laparoscopically means that the abdomen doesn't have to be opened. All you have to do is to make a small sub-umbilical incision. You pass an endoscope via that incision, and then you can operate through that. So opening of the abdomen can be avoided. But remember, if the patient is in a state of shock, then you don't go for laparoscopy, you go for open laparotomy. But if she is somewhat stable, you can go for laparoscopy. Now, surgical management in surgical management, you have different options. The first option is self-injectomy. Self-injectomy is that you remove the ruptured tube. The tube has ruptured and you have removed that tube. And this is best surgical management. But before going for self-injectomy, you must have a look at the contralateral tube. What is the condition of the contralateral? The surgical option is self-ingotomy. Now, what you do in self-ingotomy is that the tube has not ruptured. There is a large mass, tubal mass, but the tube is still intact. So in that case, you have this option of doing self-ingotomy. And what you do is that you give a linear incision over the tube. Through that incision, you just remove the contents. You move the conceptors or the contents, and if that incision is not bleeding, you leave it open and then it heals spontaneously. Self-ingotomy is usually preferred in those women in whom the other tube is also damaged or it has already been removed, or you don't, or those in those women who don't have any children before. Because there is a possibility that when you do self-ingotomy, the risk of another tubal pregnancy in that tube is increased. Because I told you in the etiology that one of the causes of ectopic pregnancy, tubal pregnancy, is damage to the fallopian tube. So when you are doing self-ingotomy and you leave the tube, the risk of recurrence of ectopic pregnancy in that tube is increased. But you only use this option in those women I've told you that in whom other tube has already been damaged or removed, or they don't have any children, you want to give them a chance. Otherwise, in those women who have children, the best option is that even if the tube is intact but has tubal pregnancy, go for self-injectomy. Is surgical management clear? Are people with me or not?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Any questions so far? जी, any questions from you people? मुझे सिर्फ 2 लोगों की आवाज आती है. कितने लोग हैं जो लेक्चर अटेंड कर रहे हैं?
Ma'am, इस time almost 87 attendees.
87 people.
And I can hear voice of others are silent. चले, any questions?
मैम हम यही हैं.
अच्छा, any questions? वो आपके मॉनिटर हो रही होगी अटेंडेंस. आप फिक्र मत कीजिए. Any questions? या तो सब कुछ क्लियर है या कुछ भी क्लियर नहीं है. अगर कोई सवाल नहीं है जी. Any questions?
No question, ma'am.
No, ma'am.
The last is the last point is that those women who are rhesus negative, rhesus negative or Rh negative and they have surgical management of ectopic pregnancy, they must receive immunoglobulins within 72 hours of the procedure, and the usual dose is 50 microgram. This that those women who have undergone surgical management of ectopic pregnancy are rhesus negative. They must receive immunoglobulins because otherwise there is a risk of rhesus isoimmunization in the subsequent pregnancy. So this is very important, which should be remembered. So no questions?
Excuse me, ma'am.
जी
मैम एक क्वेश्चन है
जी
मैम सर्जिकल मैनेजमेंट के बाद इफ द पेशेंट रिमेन्स फर्टाइल तो हाउ लॉन्ग वी शुड एडवाइज देम के दे शुड वेट बिफोर गेटिंग बिफोर कंसीविंग फॉर द नेक्स्ट टाइम, लाइक उसमें भी कुछ मैनेजमेंट उसमें भी टाइम पीरियड होने चाहिए, जैसे मेथोट्रेक्सेट के लिए तो आपने बताया 3 months दे हैव टू वेट, सो व्हाट अबाउट सर्जिकल मैनेजमेंट?
Methotrexate के बाद 3 months इसलिए because that is a drug which cause teratogenic effects on the fetus.
Yes, ma'am.
So in that 3 months, contraception after methotrexate is very important. Here, after surgical management, there is no such thing. So, and obviously, ectopic pregnancies, they occur in women who have low fertility. Remember, who either conceive late or they have low fertility. So in these women, there is no specific time period that they should avoid another pregnancy, but since they have undergone a surgery, they can avoid for say 4 to 6 weeks or 6 to 8 weeks. But here there is no specific time period that they should be advised to avoid pregnancy. After medical management, there is a logic that they should avoid for 3 months because of the teratogenic effect of the methotrexate injection. जी समझ आ गई बात?
जी मैम, और मैम इफ पेशेंट मिसकंसीव्स तो उसके अंदर क्या गाइडलाइंस होती हैं कि हाउ लॉन्ग दे हैव टू वेट बिफोर गेटिंग प्रेग्नेंट फॉर द नेक्स्ट टाइम?
नहीं, आई डिडंट गेट क्वेश्चन.
मैम अगर मिसकैरेज हो जाए तो उसमें कितनी देर के लिए वेट करना है बिफोर कंसीविंग फॉर द नेक्स्ट टाइम? उसमें भी है टाइमलाइन?
देखिए, किसी का भी अगर मिसकैरेज हो गया है अगर, तो इट इज बेटर टू अवॉइड प्रेगनेंसी फॉर अनदर 6 months. ठीक है?
Okay, ma'am.
आप तो करेंगे, लेकिन इतना हार्ड एंड फास्ट रूल नहीं है आफ्टर मिसकैरेज के जरूरी करें. बट इट इज बेटर टू गिव सम टाइम कि भाई हेल्थ भी इंप्रूव कर जाए, थोड़ा सा टाइम मिल जाए. Maybe 6 months. If somebody is very keen, then you can save for 3 months.
Okay, ma'am.
जी. Any other question? बस? No more questions?
No, ma'am.
Okay, thank you.